Okay, we're going to go ahead and get started. Folks will still continue to come in and introduce themselves in the chat. That will be great, but we're going to go ahead and get on with our business here. So we can move the slide. So the objectives for this series, as I said before, this is number 5 in the series. The objectives have been to raise awareness about young children and their families encountering or involved in the child welfare system, to educate participants about racial disparities in family separation from child welfare involvement, to promote opportunities and strategies for prevention for families and communities, and to provide examples of cross-systems collaboration on behalf of our youngest children. For this particular webinar, our focus is on the Family First Prevention Services Act. We are going to have 4 panelists with us today, and through their conversation, we will be learning about the FFPSA and how it is being used nationally to expand home visiting in particular, and just a whole overview of FFPSA and the opportunities that it is creating on the ground. And then we're going to take a focused look at Illinois' expansion of home visiting under FFPSA. First, we're going to have a little bit of an introduction to the Erikson DCFS early childhood project that manages the home visiting expansion. And then we're going to really get into some conversation about how the challenges have been met that have been encountered as they're implementing home visiting there. So that's what we're going to do today. And next. These are our panelists. First is Claire Anderson, who is a senior policy fellow at Chapin Hall. Pfeffer Eisen, who is the director of the Erikson DCFS Early Childhood Program. Faye Gerges, manager of Erikson DCFS Home Visiting Program, and Andrea Goss, the Associate Vice President, Clinical and Community Services at Erikson. I am going to ask them to introduce themselves to you as after one more slide. Okay, how to participate. So first of all, introduce yourself in the chat. As we said, we're going to have a poll shortly, right after the introductions. And then we want you to put your questions also for the panelists into the chat or the Q&A. And then we want you to complete a survey at the end to let us know how we are doing. Okay. Can we take the slides down so we can see everybody? And we're going to do the poll first. Okay. All right, everybody, we're going to do the poll first. So just you'll see the poll. It's only got about 4 questions. It's pretty straightforward, just trying to understand who's here and what your background is in terms of any understanding of FFPSA and home visiting. So take a minute, answer these questions, and we will go over the results as they come in. Okay, just another minute or so. Jonathan, are we ready with our results? Okie doke. So we have about 47% of you are from early care and education, and another 25% from other early childhood programs. And we've got about an even number of folks coming from child welfare or in something adjacent to child welfare where child welfare is a priority. And how well do you understand the child welfare system in your state? So only 4% said not at all, so that's great. 39% understand some, almost an even split among those who understand a little and a lot. So very good. We also have 5 experts on the line. Awesome, welcome. All right, we're always happy to see the experts. All right, do you know of any change efforts currently underway in your state that are targeting children and families in child welfare? So about half of you do, and a little less than half of you don't. So that's great, because for those of you who do, hopefully you'll have some information that you're able to glean from our presentations today that help you get involved. And for those of you who don't, maybe you'll have some ideas about how you can get involved. How familiar are you with the Family First Prevention Services Act and the plan in your state? And so these numbers are fairly evenly distributed. Just a little bit said 34% of you. About 20% said some, 24% said not at all. Again, we have experts, 5 experts that are with us on this topic. And then, do you work with home visiting in your state? Again, we're kind of half and half. A little more than half do not work with home visiting, but almost half of you do work with home visiting in your state. So we're hoping that this will be really informative for you. Okay, let's take the slides down. I'd like for all of the panelists to be able to introduce themselves. Wonderful. So Claire, should we start with you?
Absolutely. Hello, everyone. I'm Claire Anderson, a senior policy fellow at Chapin Hall at the University of Chicago. And we are working with states across the country to plan and implement Family First. So I'm delighted to be here with you today.
Thank you, Claire. Happy that you're here. And who's going next? Andrea.
I couldn't get my mic to unmute. Hello, everyone. Good afternoon. I am Andrea Goss. I am the Associate Vice President for Clinical and Community Services at Erikson Institute. And I've had a long history in working in child welfare. So I'm excited to be here and excited to be amongst you all to talk about this very important topic.
Thank you, Andrea. Pfeffer?
Hi, everyone. My name is Pfeffer Eisen. I am the director of the Erikson Institute DCFS Early Childhood Project, a project that has existed since 1998, mostly actually under the direction of Andrea Goss before she became Associate Vice President, where we are working really hard to help the child welfare system connect young children and their families with the services that they need to truly thrive. I also have been in and around child welfare my entire career, and I started in residential treatment, which really fuels my desire for us to make use of early childhood services to change trajectories earlier by using the information we have to make better decisions in the beginning. So it's wonderful to be here. Thanks, everyone.
And amen to that, Pfeffer, and thank you. Okay, Faye, you're the last one.
Hello, my name is Faye Gerges. I am the home visiting clinical supervisor, also with Erikson DCFS Early Childhood Project. I've been with the project for 8 years. Prior, I've had extensive work also in other forms of child welfare and domestic violence. But in July 2020, I took the position as a home visiting clinical supervisor. I oversee a team of home visiting specialists that act as liaison between child welfare and home visiting programs across the whole state of Illinois. And I have to say, creating a program during a pandemic is definitely challenging, but I guess if you have to say of how to connect through the whole state virtually, what better time to do it, right? So.
Right. Right. Good point. Thank you, Faye. All right, everybody, you have met our panelists. Let's get going. Claire's going to start for us.
Terrific. Thank you so much again for having me. And we're going to start with just this cover slide to think a bit about family first and home visiting. I think there are a number of emerging considerations as we've seen a number of states submit their plans and begin trying to, in many ways, I think what you'll hear from me over the next 15 minutes or so is the potential for redesign of the front end of child welfare. I'd say that's the headline here, that we are seeing emerge from states across the country, some innovative thinking that really tries to lift up the intent of this piece of legislation to prevent entry in foster care and to prevent child abuse and neglect, as the legislation requires of the clearinghouse to identify outcomes related to prevention of child abuse and neglect. So let's go to the next slide and just frame for a minute two really important redesign things that we see across the states. And I'll talk about each of them. The first is that home visiting has really become central to state family first approaches. And the second is seeing states interested in developing community pathways to ensure that families are getting services early and on platforms that are non-traditional for the delivery of child welfare services, that really are on platforms like home visiting that allow us to connect with families where they have trusting relationships and where they are more often to seek services and supports. The first one, actually, let's go to the next slide and I'll talk about each here a little bit. Why don't I just start with the national landscape? And this was a point in time look at approval and submissions of plans. So it may have shifted a little bit in the last couple of months. But a reminder, the prevention component of Family First is a voluntary component of this piece of legislation. And that we are seeing this number of submitted plans is nothing short of remarkable, and a wonderful bellwether of what's to come in terms of state appetite for creating a different context around prevention for families. And so I think we all should celebrate that there is an openness, a willingness, and interest to take up the mantle that Congress put before states to really provide prevention services. Everyone will recall that the legislation allows for mental health prevention and treatment services and programs, substance abuse prevention and treatment services and programs, and in-home skill building programs and services. And so it's not a surprise that we see such appetite around home visiting, particularly given the additional construct of really encouraging and incentivizing states to take up well-supported interventions. So let's go to the next slide. If you walk away with nothing else from my 15 minutes here with you, it's this slide. Even I, who've been reading Family First plans and helping to develop Family First plans and reading all of them as they've been coming through, when we did this crosswalk, I was quite taken aback by the magnitude of the scale up and expansion of home visiting that is contemplated via Family First. This is nothing short of a seismic change in child welfare services. I'm just going to let that word sit for a minute. It is a seismic change in how states are contemplating services. and where and how much they are thinking about the implementation of home visiting as a core strategy. Even I kind of get overwhelmed here at how thrilling this is to think about the deployment of home visiting, a voluntary service, a service that really is focused on family strengthening and meeting needs early as a core way to prevent child abuse and neglect and involvement with child welfare. So this is the big takeaway. That we have a lot of work to do collectively, collaboratively, together, and across these systems to realize the scale of what we see here. Okay, so next slide. I also want to talk about community pathways because they are interrelated in some ways and not in others. Community pathways, we are seeing states say through their Family First prevention plans that they want to be able, that they are interested in the flexibility that has been provided in the Children's Bureau Policy Manual, section 8.6C, around contracting out many of the administrative functions in Family First, in addition to the service itself. And I have a number of slides that will talk a little bit about what that means technically. But just at a high level, states really are thinking through, how do I resource community organizations, family resource centers, partner with sister public agencies to identify families early and ensure that they are receiving services on a platform that they are likely to trust, that they will stay engaged with, and they will complete services to reduce risk and reduce future involvement with child welfare. So we've seen about 13 states at this point, maybe a few others have, at least 2 others that I know of, submitted plans. We have now 2 approved community pathways, Washington, DC, and the state of Connecticut. The remainder are awaiting approval with the Children's Bureau, and we've seen a number of connections being made to further a dialogue there to make that possible. Okay, I'm going to go through the next 4 slides relatively quickly because I want you to have a little bit of the technical. So what does this mean on the ground? Families, as you all well know, typically in child welfare, though every state is very different, follow a path into child welfare involvement that starts with a family, a mandated reporter or a reporting source, a hotline call, an investigation, and then a set of services that are provided or a set of referrals out. And there are a number of administrative functions that occur in this process, including developing prevention plans, safety and risk monitoring, case management if indicated, and then eventually a referral or a partnership with a family resource center or a private provider like someone or a public agency that's providing home visiting would become involved and run alongside or would be the primary interface with the family. Next slide. States are starting to think about it like this for community pathways. What if a family was identified by one of those organizations, by a home visitor, by TANF, by housing, by a family resource center, as having a set of factors that were agreed upon previously that would meet the criteria of a candidate for foster care, and identify those families and then have the 4E agency, the child welfare agency, make the determination that a child is a candidate, and that the service delivery and the administrative functions that you see here on the left would occur off the child welfare platform, but with an interface so that reporting reporting, so that aggregation of data and reporting to the federal government about who's receiving services can continue. But this really is is contemplating a redesign of the family user experience in child welfare. So next slide. And I'm going to skip to the next slide just for time's sake. One example, though, as I've said, there are probably 13 or 14 examples out there. The California plan has this nice visual. This is a plan that is submitted but not yet approved, of whereby the agency or a lead community-based organization would conduct an assessment of family strengths and needs, make a decision that this family might benefit from a service array that's connected to Family First, be in contact with the 4E agency through a portal that they have determined previously, and then the determination of candidacy be made, and the family continued to sit on a CBO or a family resource center or a different platform like home visiting, for example. The Indiana prevention plan has oriented it in that way so that Healthy Families America is the proposed platform through which all of the services and supports to families would occur. So next slide. So this brings up a number of opportunities and challenges. I'll just sort of briefly highlight those as we transition to the other speakers. The first is really increased investment in community-based organizations and home visiting capacity to engage and serve families. You know, hearkening back to that second slide of the spread, the scale that's contemplated here, a much deeper investment in home visiting through trusted community agencies and home visiting. Families would experience these services outside of the traditional child welfare paradigm. Some flexibility in how community pathways are being conceptualized across the country. We're seeing different ways in different states, and I think that's really exciting. So for the 53% of you who see and know that there are changes afoot in child welfare, I think very much they are. And we see states really thinking focused in a family-centered, prevention-oriented way, unlike anything I have seen in the 30 years that I have been involved in child welfare. And certainly, I think this provides a building block for stronger partnerships. Next slide. This is not without a set of challenges. States really are asking for smart flexibility, as Senator Wyden calls it, in his recent press releases regarding Family First, and really are pressing for the provision of smart flexibility from guidance from the Children's Bureau. There's certainly a capacity question here in how we will collectively meet the capacity that is needed to be able to meet the needs of families. There's certainly a dialogue in the child welfare system around how do we increase access to prevention services without increasing surveillance of families, particularly families of color, while at the same time being quite mindful that surveillance is one component of a structural problem in policies, but also the systematic deprivation of resources is also a structural problem in our policy paradigm, and sort of balancing out those and being really mindful to use continuous quality improvement to make sure that any of our shifts that are happening are not increasing involvement in foster care and kids coming into foster care. There's a need to really balance data reporting requirements with family consent and privacy, maximizing community agency and helping them to make decisions about what's needed, and balancing that against some of the required functions in child welfare. And this last one I've noted, just building the infrastructure and the capacity to do this. home visiting is a voluntary program, and we want to make sure that it remains true to its prevention of child abuse and neglect. And we're very much looking forward to continuing to be in dialogue to help think that through. So that you can go to my last slide and move to our next speaker. Thank you all so much.
Thank you, Claire. That was very informative, and I hope that, well, we've got definitely a number of points that we'd like to follow up on when we get to our Q&A. So thank you for that. We're going to move now to our team from Erikson and turn it over to you guys to get started. And now it's your turn. Whoever's starting.
I'll pick it up here, and I'll talk briefly about the Erikson and the DCFS collaboration that has existed, as Pfeffer said, since 1998. And then I'll kick it to Pfeffer and Thay to talk about what the department is doing in response to Family First and home visiting. So briefly, I'll say that Erikson Institute, a premier graduate school in child development. I'm sure many of you guys know that it has academic programs, largely focused on academics. What you may not be well aware of is that there are clinical programs at Erikson that both inform academics and academics informs us. And so we have this kind of intersectionality that allows us to work together and to really stay on top of what's best in terms of child development and what's best for families with little kids. So the DCFS Early Childhood Project started in 1998 by my predecessor, who really, she's an Erikson alum, and she really had the understanding that we weren't quite doing right by the young kids in child welfare. And as a young person in child welfare myself as a caseworker, I remember some of the ways in which I managed very young kids or my caseload, and I cringe as I think about it. And so the person who started the project, who's long moved on, she brought the idea to DCFS to start this project whose sole purpose would be to support very young children who are involved in child welfare, who's had those adverse experiences and experiences of loss. And we wanted to really focus on how we can meet those needs of those young children that had not really been paid attention to before. And so the department said, yes, we want you. There were other things that were involved in these discussions. You know, we'll talk about the great part. And the part is that the department, they were open and they decided that this would be a great idea for young children. And we started off very small in Cook County with just a few clinicians. And now we are a statewide program of 35 clinicians who are still fighting the good fight in terms of helping the department to meet the needs of young children better. Next slide. I think I'll talk over my slides. Okay, yeah, so this slide represents collaboration, right? We're talking about cross systems work, cross agencies work. We often sit at the table when we are thinking about what's best for our little ones and how to continue to make improvements and to really put our actions behind our words in terms of support and well-being. We sit at the table and we work on it. It's a group effort. Next slide. This is how it mostly is, though. That previous picture of like-minded people coming together with great ideas, it often turns into an exhausting experience that often leads to us probably having to course correct or reconsider or regroup in different ways. But I have to say that one of my joys and working on the project has been those moments when we were able, under Dr. Cynthia Tate's leadership, to galvanize people behind our mission. And it happened a lot more often than one might imagine. We had our fair times of difficulties, but oftentimes, because we were able to come together to the table with that little puzzle and work things out, we were able to do lots of good work that you will hear about from Faye and Pfeffer as they talk to you guys about how we are responding to Family First. And so I'll stop there because I probably talked too long, and I'll let you guys go.
Could we have the next slide, please? So Family First is not the first time that either legislation or a consent decree transformed the child welfare system, at least in Illinois. While it's not important, this was also the basis of helping get our project going. And the focus was very much always on identifying the needs of young children and making referrals to the agencies that could help serve those early childhood needs. For example, early intervention is a very large state system that we facilitated making referrals to. Could I have the next slide, please? So this slide is really about how we think about all of our work, whether it's home visiting or linking young children to early intervention or participating in Family First. The Erikson Institute, as many of you probably know, is very much aligned with the idea that it's all about relationships. And without the relationships, learning doesn't happen for children. These are our ideals. Our staff do not work directly with the children providing services. So we are solely in the role of creating relationships between outside service networks and the child welfare system. And many people, when they hear that, say, oh my gosh, isn't that so inefficient? Why in the world would you need people who need to do that? Why can't the case manager just do it? And I think what we have learned over many years of doing this is that all systems, whether you're talking about child welfare or early intervention or home visiting, all systems are very clear to those who are in that system and very opaque to those outside the system. And so having people whose job it is to know not just what services do, but how systems work becomes very important. When we say we're parent-child centered, we mean we're listening very carefully to whatever the caregiver or parent has to say about the child and understanding what they think they need. And we are working to try and help people understand that services that are offered for young children are not necessarily punishment for child welfare involvement. Instead, they are supportive services that can actually help your family do the things that you believe are important for your family. And so doing this work with early intervention for a long time prior to Family First really put us in a good position to be the people who are able to help build relationships between child welfare system and home visiting. Can I have the next slide, please? So the case manager is everything in terms of creating these relationships. One of the things that is truly amazing to me is the extent to which case managers are asked to make referrals or identify needs for just thousands of possible different needs and services. And so we see ourselves first and foremost as partnering with case managers. We believe that if we provide them with a place to bring their concerns, as well as with the family, that we can all come together to work to think about what will best meet a family's need at one time. A lot of times in child welfare, you can get very, it's easy to have a laundry list of issues that need to be addressed and insert a service for every issue. We also partner with case managers to try and help them think about what is the biggest priority, or is there a service that could possibly meet multiple of these needs? Can I have the next slide, please? So in Illinois, we have something called Intact Family Services. And this is the primary audience for Family First Prevention Services Act services. Now, I have to say that we're going to talk about creating relationships between child welfare and home visiting using Family First. Illinois' Family First Prevention Plan is much more elaborate than just this part. We are but one part. So there are multiple different clinical services that the state is using Family First to try and fund. And really we're targeting intact families. So that means that there's been allegations, often indicated, and the family has come to the department's attention. And yet we are really working hard to try and maintain the children in that home and give the family the support that they need. Again, our project is well positioned to do this with home visiting as well as other services, because already we receive notice of all young children birth to 3 and newly opened intact cases. That allows us to reach out to case managers to offer that consultation I was talking about earlier. And we often collaborate to assure developmental assessment or direct linkage for early intervention. Home visiting is a perfect addition to this, because often we may see kids who, for example, need enrichment, or parents who have concerns for their children's development, but they don't necessarily require the intervention that early intervention offers. It's a little too intensive. And you'll see this word a lot, relationship-based referrals. This, I think, is something that we become more and more attached to. So what we learned for many years is that we could assess kids and make referrals, and we didn't know what happened. And so then probably 5 or 6 years ago, through an initiative of one of Illinois' DCFS directors, where she said, well, you assess, and then what? We said, oh, well, maybe we should try and find out. And so we started following up on early intervention referrals. And what we found out is that the ways in which referrals cannot happen, the way that things can get dropped, the ways that families can feel misunderstood and not want the service, or not have the service explain to them in a way that helps them feel like it is something that can help them, are many. So again, we have this team of people in this role who are trying to create relationships between child welfare and home visiting. Next slide, please. So home visiting, very briefly, because Thay is going to get to what this looks like on the ground. The idea was that we would use Family First Prevention Services Act eventually to hopefully get the state of Illinois some reimbursement for home visiting services. But where it started was DCFS recognizing that early childhood home visiting really improves both child and maternal health outcomes. There's a lot of belief in the power of the early relationship, and home visiting can provide a lot of supports that are really based around what the family needs. So if you think about child welfare, intact family services in the state of Illinois is designed to be short-term. It's to get families linked with supports and then hopefully exit the picture. Home visiting is an excellent match because the case manager from DCFS may be involved for a short time, but the home visitor can remain with a family for years and continue to provide that support and that trusted relationship. So we set about, I guess 2 years ago when Faye was promoted, we started with one position, and then we developed a team whose job it was to really target young children who are involved in these newly opened intact family services cases and offer these parents this voluntary service and create ways that it could be presented to families by case managers as a voluntary service, even though child welfare is not experienced as a voluntary experience. Next slide. So I'm going to kick it to Thay, who's going to talk a lot about the on-the-ground process of building these relationships. I will say that the data problems and the financial things to figure out that Claire spoke about earlier are also in progress. But really the work was started with the relationship building first. So that's what Thay's going to talk about.
Sure. So when you have covering home visiting referrals for the whole state of Illinois, there are so many different programs when you think of which curriculum, what funding, what sort of source, and it can become really complicated when you think about catchment, eligibility. And so what we've realized is, like, our goal is to try and express this in a simple way. I mean, the whole point of home visiting is to help parents and young children feel connected with each other and their community that they reside, and just how to make it simple in expressing this. And really part of our conversation with caseworkers is, do you have a child 3 years or younger than 3 years, or a pregnant mom that you think is actually interested in a free, voluntary, long-term supportive program? And then let's talk about the specific ways that home visiting can help. And as part of it, by sharing what home visiting can do, we can then talk about what's really helpful for the family. What interests and concerns does the family have? How can we kind of reduce duplication of services? So a lot of this is just kind of like, how do we simplify this to actually be meaningful and helpful for families and caseworkers? Can we go to the next slide? But before I go into data, just as Pfeffer talked about, like kind of our role as kind of helping the cross systems work together, we just want to recognize that there are a lot of questions and concerns that we hear both from the home visiting side and the child welfare side. We recognize that when you are serving families in crisis, the potential for all of us to get frustrated with one another is really high. And I've just actually on this slide have listed actual questions that we've received from home visiting programs. Home visitors have a lot of concerns of what does it mean to take on families involved in child welfare. When a home visiting program is more familiar working with first-time teen moms, it can feel extremely different when you've got older moms with multiple children, and especially when this family has had multiple losses and crisis and trauma. And so it is a very, it can just feel different from the work. And so that's why I think it's really important that we understand how much a home visiting agency can take at a time, encourage the use of infant mental health consultants. Just as a home visiting provides a reflective space for families, we realize that they need to have a reflective space to process this through. And I'm just going to read actually an email that this one home visitor sent after her first visit. Our first visit was an hour and a half. Mom had so much to share. At one point, I was ready to run, as this is my first DCFS case, and I wasn't sure I could handle it. But as I observed the little ones, I knew I needed to stay and assist this family as much as possible. Mom seems very interested in participating in our program. I will definitely reach out if I have a hard time connecting with this parent. I love this honesty that she's going through, and just recognizing that the more just, and what I've heard from a lot of home visiting agencies that are initially anxious, is that as they start to work with families, they start to realize this family is actually no different than other families that I'm working with. And so it's trying to transition out of those families to our families, just in general, overall. If we can go to the next slide. So as you heard from the home visiting, there's this concern of the switch from prevention to intervention. It's actually kind of the opposite switch for child welfare. They are struggling to kind of consider, what does prevention mean? And we have to pause and realize that they are managing risk. They are stabilizing the family. They are thinking through multiple interventions for multiple family members. And so there are good questions as to why they are thinking through all of these different problems that they're having to work through. And it can be a little different to think about prevention. But what we try and keep expressing to caseworkers is, don't think about this as a service to complete. Think about this as a relationship that can provide long-term support for this family, kind of like their go-to person. So part of this is just kind of meeting where the questions are and talking it through for both sides. Let's move to the next slide. So with Family First, they talk about a target range, which is families with children 6 months and younger and pregnancy. I tend to call it the sweet spot when I have different conversations. Like, this is where we just know that the sooner we get in, the better for prevention reasons. When you think about it, bringing in a new life can be an open door possibility. not just for intervention, but just a receptiveness of the family. For example, we had one referral where this mom declined when we explained home visiting to her. But after she had her ultrasound, she realized she was pregnant with triplets. So she changed her mind and she agreed to go forward with a referral. And she actually made it to even engaging for that 6 months, because that's what we do. We don't just make referrals. We try and actually help through the enrollment process and check in monthly to see, do they stay for 6 months. But we do need to start thinking so much more about our pregnant moms, because already what I'm seeing with our mothers is that they've had very complicated pregnancies, prematurity, low birth weight, substance exposure, maternal medical and mental health concerns, and even infant mortality. So our families are at high risk for infant and mental health and morbidity concerns. So we need to think, how do we connect in here? Next slide. So as you see here, we want to identify our sweet spot. The lower bar shows that in our very first year, we were building our system of how we were going to receive and make referrals. And what we found is that majority of our referrals were 2-year-olds at the point of case closure. And so we realized we had to switch. We had to think about doing things differently. And so as you can see in year 2021, the middle line, we definitely were able to address some changes. We were able to identify over 500 families that were either pregnant or had a child 6 months and younger. A big part of that was that we changed our perspective of not just receiving referrals, but doing outreach. Just as Pfeffer talked about, where we received notification for every family with a child under the age of 3 involved with a newly opened intact case. So what we ended up doing is our home visiting specialists, we started this in February of 2021, and it took it to really be in full effect until November 2021 across the whole state. But we just started to do outreach for caseworkers when a case recently opened and you had a newborn, you had a child under the age of 7 months. And as part of it was just to begin the conversation. We didn't view it that it was automatic referral for home visiting, but it was just to begin, again, that conversation. And so you see that now in 2022, and remember we're in March, but we're already hit over 300 identified families in this sweet spot. Can we go to the next slide? So this is just kind of like a general overview of what we are trying to do in connecting families from identifying, offering, referring, enrolling, and staying engaged. And a part of what we are constantly looking at, just as Andrea had her one slide, is what's working and what's not working, what makes us realize this is actually too complicated, we need to change or address. If we can move to the next slide. So last year, we did identify under 700 families, and a third of them led to referrals. And I think as part of our outreach, we've realized we are doing a lot of consultation too. So if we're putting our place to initiate, it's not about we have to make home visiting happen. It's more about what does this family need? What sort of other connection? So a lot of even what we're doing isn't just connecting to home visiting, but linking to other representatives within DCFS or a different type of early childhood resource. Next slide. And there are challenges. Almost, it's around 40% of our referrals lead to enrollment. Part of it is yes. Parents may say yes at the point, and then their lack of response is an answer. But we found that actually isn't most of our situation. We have families that are just in constant crisis. They do not have the documentation that they need to get through the enrollment process. They are constantly moving. There are just disruptions that happen. And I could go on and on about specific stories of house fires as reasons why they can't provide certain documentation, and we just can't move families in that direction. And so there have been a lot of conversations with funders and with advisory groups of how do we do things different to help our families get through sooner, and recognize let's actually view home visiting as a support to actually get then the needed documentations that these programs need. If you can kind of move to the next slide. And this is what I kind of love, is that once we get families into a program, we find that they are sticking. And this is what we have found for our unique place, where we can actually even track even after an intact case close. Yes, it's true, some families will stop once the intact case has ended, but there are families that are sticking with it. And so we can see that this is just beautiful to kind of realize, like, families are getting the support that they need. You know, so we hear really unique stories. You know, I mentioned that mother with triplets, she made it to her 6 month mark. We're hearing how parents are learning how to read their baby's cues and emotions. They're getting the support to get older siblings into preschool. Parents are getting GEDs, jobs, stable housing, just different accomplishments. And when we stop and think about how our families are in just constant crisis, and they still have a number of challenges ahead, it's great to hear how life can start to feel a little bit more grounded and predictable. And so I just want to kind of give that was my quick overview. I know that Dr. Tate is wanting to kind of move us towards a panel presentation.
Thank you so much, Faye, and thank you to all of our panelists. There is so much to say here. It's just like where do you start and why don't we have more time? But let's start in this place. I wanted to give an opportunity for panelists to kind of, have an interchange with each other. And I would like to try to, sorry, that was my timer.
We're on time.
Yeah, we're doing good. I wanted to pick up on this idea of the seismic shift. I love that that term, Claire, that you used, and I think it really does give us a sense of how major this is, right? It's seismic. And so in thinking about Illinois and the long history of this cross-system collaboration, right, between child welfare and early childhood through the Erikson DCFS project, and how much infrastructure and experience there is there, and yet these challenges that Faye was in particular going over remain. They're working on them, and then I'm thinking, well, if we've got a state that has this kind of history, this kind of infrastructure, and we've got this kind of seismic change occurring in the rest of the country, then there have got to be states across the country who are really struggling because they maybe don't have the benefit of this history. So I'm wanting you guys to reflect on both, maybe Claire, from you, what kinds of things are you seeing that states who are brand new to this are in particular struggling with? And the Erikson team, I'd like you to think about, if you were to speak to a state who hasn't done this before and is starting to do this because FFPSA is the opportunity to do it, what would you tell them? So what do you guys, what are you thinking when I ask those questions?
A couple of things. One is that I think from what we're seeing across states is both a deep interest in scaling up home visiting to meet the needs, and just wanting to tap into the existing system, and this sort of tension between how do we go about maximizing the home visiting system that exists, but also anticipating the need for more home visiting. I don't know that I have a great example yet of where there is a deep engagement to truly make it happen, other than perhaps New York State, where home visiting and child welfare both sit under the same umbrella of its public agency. And so the people are together already. And they have centered much of their prevention plan on Healthy Families America. And so they are thinking together about what the implications are of that set of decisions. So I don't think that I have a very concrete answer for you. We are still so early in the implementation of Family First. The legislation was passed in 2018, so it feels like, you know, we're 5 years in. Surely we should have this figured out already.
But, well, not for anybody who knows how government works. It's not, nothing's fast.
It's not fast. We only have 22 plans approved. States are really, and the claiming, the fiscal claiming by states is well under what was anticipated at this point. So to the extent that this can be a transformative policy, it is the technical aspects of it are still in the works.
Yeah, makes sense. Thank you, Claire. Thanks for that.
I'll jump in for a second. I'll say that 3 decades of working in child welfare, one of the things that I've always wanted to do was work myself out of a job. You know, and that would mean that the integration of what I was bringing to caseworkers into the case and to supporting the family, it would all be integrated and they would make great use of it. And they would basically just take my ideas as, you know, as I give them to them. But of course, that's not the case. It's much more difficult than that. And I don't have like a direct answer to your question, Dr. Tate. What I will say is that, you know, anyone embarking on this endeavor definitely have to be patient. And also recognize, and I think Pfeffer spoke to this earlier, that the child welfare systems are struggling with so much. And it's often the case that when things fall through the cracks, that the caseworker is held responsible, or the supervisor. And it's typically systemic issues that are creating these gaps or allowing these cracks to happen. And so I think embarking on this, understanding what the experience of a person who works in child welfare, what their experience really is, as opposed to what you might think it is, and have an openness as you approach, you know, those conversations. I said patience, openness. I definitely think that, well, obviously buy-in is extremely important. And in order to do that, I think starting at the top with the at the executive level is absolutely necessary, because we want them to buy into it and we want it to trickle down. Yeah. I think what's been missing so much in child welfare, and you know this, Dr. Tate, is that there's not space to sit and think and reflect and to wonder. You know, there's no space for that. And as much as we've tried to help them to cultivate that, you know, crises and pandemic and life and all those things. So it's not an easy lift. Because the Early Childhood Project had been in existence, we had a wonderful infrastructure, but we still had lots of problems. And I have not worked myself out of a job. So
really? Not yet.
No, I'm still here. I'm still here. You know, so it's going to take galvanizing and focus. You know, there are always red herrings that come in, that pop up, or there's a problem, and the response to that may be to create a workaround. I don't like workarounds, because eventually you're gonna have to deal with that issue. Mm-hmm. So you have to sit there at the little table with the puzzle pieces, you know, and think it through and work it through. And it requires commitment, flexibility, patience, and true desire to want to change.
Yes, absolutely. Well, there was a lot in there, Ms. Goss. One of the themes, we've got several themes that are coming up in the questions, and thank you, audience members, our participants, because your questions are great. We've got some themes that have to do with relationship, some themes that have to do with funding, And also, I want to put on the table at this point in our conversation this issue around disparities and diversity or lack thereof in the home visiting workforce. Can we just talk about that for a minute? We know that there are racial disparities that are horrendous in the child welfare population. We understand, I think it was in your presentation, Claire, where you talked about wanting to increase access to prevention without increasing surveillance. And we know that surveillance is a real key word when we start talking about what's creating disparities. We have a question that somebody's asked about, are we reimagining mandated reporting? But let's have a little bit of a conversation here about disparity and diversity in the cross systems collaboration between these two systems. Whoever wants to start with that. Pfeffer?
I think that's a really big question. The first step is just to acknowledge the truth in all of it. People of color are wildly overrepresented in the child welfare population. And so putting on the table at whatever meeting and whatever collaboration you have that is an issue and is something that needs to be dealt with is really true. You know, the efforts for the home visiting workforce, I would hesitate to speak to because there are different home visiting funders and organizations that deliver home visiting. And I don't have sort of, they talk a lot about their efforts, but I wouldn't want to accidentally misrepresent them. But what I would say is I would go back to what Claire is talking about. So part of what we're doing is trying to articulate the need for home visiting and the need to resource this workforce because people want to get out of surveilling people. And the other part is you have to bring in the people you're serving at every level. Like wherever you're making a plan, you should have some users of that service there, right? So we talked a lot about the case manager, but also incorporating family voice. I think one of the things that I'm hopeful about in Illinois is our evaluation team is already working on surveys of home visiting workers and child welfare workers about what their experience is and what they need. And also we have plans to talk with families about their experience and what they need. All of that is just really hard though. I mean, it's really hard, it's painful, and I have to say, you just have to get comfortable knowing, at least I am comfortable knowing that unfortunately I am an actor of white privilege and I need to work on myself as well and how I think about what these things are. I think the final thing I'll say is that they referred to a lot of systemic issues that lead to difficulties with enrollment. And a lot of these requirements are really about this idea of like, oh, we don't want people taking things they aren't entitled to. Like there's a lot of cross-checking when you're delivering service to families to make sure that the funding is going the right places to the right people. And I frankly think if we want to be truly family-centered, we have to stick with what families need, and we probably have to give some of that up. That's what I think. I think we should give people what they say they need.
Imagine that. That would be a great idea. Does anybody else want to speak on this issue before we move into one of the other themes that I want us to get to?
I mean, oh, go ahead, Andrea, sorry.
No, I was just going to echo a lot of what Pfeffer said. And yes, historically, Black and Brown people have been disproportionately part of the child welfare system. And I do think we need to name it. And I do think we need to ask why. I think we need to ask why. I think we need to, again, I go back to reflection and self-reflection as a kind of a catch-all in some ways, because it allows one to really sit and examine what they're thinking and what they're feeling in relation to their clients and things of that nature. So I think having supports for home visitors as well as child welfare workers that would allow them to have that space where they can talk about what is coming up, and in those instances where there are blind spots or biases, that those be acknowledged and brought into the room and talked about. I mean, just a step.
Yeah, absolutely. And Claire, I know you've got some thoughts on this. I know you are doing some work in this area, so go ahead.
Yeah, I do. I mean, I obviously I agree across the board with what you both have just said. When you take a big step back and you look at what states are putting in their prevention plan around home visiting, knowing that they have been grappling with disproportionate representation of people of color in child welfare for years and have tried very hard within their system to reduce that disproportionality. I think one way to think about this is that they are recognizing that disproportionality and disparity comes to them at the front door or at the hotline call.
Yeah.
Right?
Yep.
Yes. Okay. We get a disproportionate amount of calls for kids and families of color. And that child welfare trying to solve this problem inside of child welfare has been extraordinarily challenging. And so I'm connecting the dots between their interest in home visiting and a deep interest in trying to make sure that services and supports are provided early in communities where families live, and accessing those services so that we are stemming that disparity inflow. So your question about the workforce of the home visiting community from a child welfare perspective becomes even more imperative beyond we're a community, and this is an important imperative for us to do because it's the right thing to do. I think from my child welfare perspective, it's even more imperative that we try and resource communities of color to deliver services that are germane to people who live in those communities, so that we are really thinking about the set of root causes and the workforce necessary to address those root causes and the resources they need. Yes. They are not inseparable. And I think that's what makes Family First and the community pathways and the home visiting intersection that we're seeing so incredibly interesting and exciting.
Mm-hmm.
It is. It's very exciting and very interesting. Mm-hmm. And so let me take off on the word resources and shift our attention just a little bit to the question of funding. And we have a question that is in our chat. Are any states offering home visiting programs as a Medicaid benefit? And I'm just wondering, so the person here says Wisconsin has prenatal care coordination and child care coordination. Both are Medicaid benefits designed to address infant mortality, etc. Their Medicaid eligibility is maintained by some families until the baby's 7th birthday. So I'm wondering, now we've got, FFPSA provides a funding structure for, the different use of 4E. What does this funding picture look like, and how can states best maximize these multiple funding streams across multiple departments, which, this is always the story in early childhood, right? We have multiple funding streams. We are structured across multiple departments. There's no difference in this conversation. But what can we say about that? How can we think about maximizing our funding for these things?
Yeah, I just dropped a link in the chat to a brief written over at Georgetown University Health Policy Institute looking at home visiting and Medicaid. So there may be some resources there for you to think through that intersection. I don't think all states are using it in that way. So some states likely have it in their estate plan, others don't. And so being really thoughtful and nuanced about the variety of funding that you have available or don't have available is, I think, a really important thing that any individual state does when it begins to think about resourcing home visiting.
Great.
4E, the fundings, there is a number of other questions that are related to this in the chat. The Title 4E funding stream, the child welfare funding stream that has been now expanded for Family First Prevention Services, is a payer of last resort. And that is integrated into the language of the legislation. So tapping all your other resources first is important. But there are training functions that, to the extent that your home visiting staff need to think about child welfare, to the extent that you're thinking about different kinds of connections and data sharing, those are all administrative functions that are new, that likely are not paid for under prior funding streams and are really required to be able to make this collaboration functional. Mm-hmm. To the extent that you're resourcing home visiting through McV, for example, and the slot question, do you have enough slots? Yeah. And if not, I don't think that Family First payer of last resort means that you would withhold additional scaling of home visiting, because there is a potential payer out there, or a payer that has been tapped, the capacity is being used. And so I think you have to, on a state-by-state basis, understand what your needs are, who your target populations are, the volume and the capacity and the variety of funding streams that you need to be able to make it work. Yes,
complicated. It's complicated. Well, let's take the last few minutes and talk about relationship. Thank you for that, Claire. As we talk about relationship, of course, everybody has said this, and we all know this, that everything is always about relationships. But there's some particular things about relationships in this endeavor that we're discussing today on multiple levels. So I'd like us to first start talking about the relationship between the provider and the family, and how this represents a very different kind of a relationship than the relationship that we have seen traditionally in child welfare service providers and their families. And Thay, I'd like you to start with that. Then I'd like us to move on and think about the relationships between the workforce of these two systems. And then I want us to then we got this other third level up here. I'm always talking with my hands. We've got this third level up here of the difference, but now that change in the relationship between the state child welfare department and the community. So we've got 3 levels. Can we give it a go here and see if we can talk a little bit at all 3 of these levels?
Okay, that's a huge ask. We'll see what.
Well, you only have to take one. Pick one. Okay, Claire wants 2. Somebody else will get 3. So just go with one thing.
I think it's recognizing it takes time for families to kind of understand that they can actually build a relationship with the home visitor. Like, we had an example where one mom had extensive trauma, loss of her mother in her childhood, a death of a child, experienced homelessness. She did not want to share her story during investigations, with her intact worker, even doing a developmental assessment with us. She even dropped out of home visiting the first 2 months because she just found like the questions were just too hard, and she just pulled away. And so we recognized that she stopped. We kind of checked in with the caseworker. It was around 2 months later to then let's try again. But it was part of it where we started realizing there are so many touch points where parents are asked to retell their story over and over and over. And so how do we kind of maybe pause and realize, like, let's build relationship and give the space for a family to tell the story when they're ready to tell it. I think that's a huge shift in what feels different versus completing other types of services that they have in regards to intact services and home visiting.
That's a great example. Thank you for that. Let's think about that second level, the relationship between the two workforces.
There's a lot to think about here.
Yes.
And I'm going to key off of a question that was in the Q&A to pose a couple of potentially provocative questions. But the first is the extent to which people have a mindset shift, right? So we often are thinking about the traditional way that child welfare works. A family comes in, an in-home worker is there, and services come in from that hub. The community pathway is really shifting the mindset of that. There are states that are standing up a community pathway where that paradigm does not exist, where the workforce in this new family first prevention space is the home visiting workforce.
Yeah, interesting point, yes.
Or is the family resource center workforce. Said differently, in 1993, in the Family Preservation and Support Act, the field made a whole host of choices about where to put resources. And they decided to resource more in-home workforce inside of the 4E agency rather than resourcing a workforce in the community to provide support and prevention. Family First offers that quite similar choice point. Some states are making the decision to maintain the workforce as it is and referrals. And some states are making the decision to resource a workforce that sits off of the 4E platform, but is connected through contractual relationships. So let me help think through one other way. We see many states that have privatized much of its foster care system, right? Right, like that, you immediately know what I'm talking about, right? Private agencies manage all the foster care. They do safety and risk assessment, they do the case plan, they go to court, and the 4E agency has a contract and there's a relationship. States have the flexibility to do that in Family First, and some are taking that option. So when we think about workforce, I would encourage you to think about it broadly.
Yes. That's very interesting. Very interesting. These are major shifts in how we're relating to each other, we with the big W. Andrea, I was thinking back on my days at the department, and we had a director who used to say, we need to come out of this house and get, and onto the porch and off the porch and into the front yard. And what he was saying was we needed to get out of this, this big house that the 4E agency is and move out into the community. And what always would happen, of course, is that there was the stigma, right? Because we hadn't been in the business of building relationship. I just wonder, Andrea, if you have some thoughts about how we go about changing that set of relationships, that big picture set of relationships that are about the stigma that has been created over all this time.
I think, that's a great question. I really think that we need to make efforts to normalize it, right? Instead of, and when you speak of stigma, I immediately go to mental health. But I know you're meaning other things in this particular discussion. And so the inability or the fear of reaching out or getting help or what have you is because of, you don't want to be labeled or what have you. And so, what we have been doing is really looking towards and it may not work in this case, so that's probably a bad example, but ambassadors, ambassadors, folks who can actually, who have been in had these same similar experiences, who can be like a connector to those who you want to engage. I mean, a number of programs have used that. We've used parents who've graduated foster care, and we've had them on advisory committees and things of that nature to help with engagement and to help us to be able to connect to the folks who really, because they get it in a way that we don't. I have to say that, you were referring to the one of the previous directors, and I do remember that speech. I do remember he was really keen on community engagement, and it made me smile today to see all of this interest in home visiting, because again, it's been a long time coming for people to really get to this point. We've been fighting this fight for a long time. I have to say that, this makes me happy that we are in this place, but I also have to keep in mind that a lot of things happen with our families before DCFS gets involved. Lots of things happen. And so as we are moving closer and closer to the beginning of that line, we need to go even further. Just like when we were thinking about birth to 3 or birth to 5, now we're thinking prenatally, right? So we really, why are we here is the question, or how did the family get here is the question for me. And that's what I have to keep in mind as I think about best ways to support families, truly support families in a preventive way.
That's right, that's right. I want to just give a quick shout out to that previous DCFS director in Illinois named Erwin McEwen. So just have to give him a shout out for that. He was ahead of his time. I just wanted to, we're running out of time, of course. And I just wanted to ask each of you if you would just take a shot at a final thought that you would share with our audience and our participants. Anybody can start, but whatever. This is a hard thing to have a final thought, because we're not at a point in time for anything to be final. We're at the beginning, right? We're at the beginning. But if you have a last thought for the webinar, not on the topic, just a last thought for the webinar and for our audience, so please share with us now.
I feel hopeful. In a way that I haven't in a long time. So I am really thankful to you, Dr. Tate, for inviting me here today to participate on a panel. I think what did it for me, other than seeing your face, is Claire's presentation and the data, and to see how much interest there is in home visiting and what that will mean for families, or what it could potentially mean for families. So that gives me quite a bit of hope today.
Oh, wonderful. Oh, it's always good to end on hope.
I agree. Like you, some of us have been around this system for a really, really long time. And to think that we might be able to serve families differently early, and prevent child abuse and neglect, and prevent entry into foster care is just, it's thrilling and incredibly motivating to stay at it. So I'm delighted to be part of this dialogue. And I'm so glad that all of this community is in a space to partner. Wonderful. And I'm incredibly grateful for Family First, Prevention Services Act. There is no perfect policy, but this policy has created a pathway for us to think about prevention very differently than our policy framework in child welfare has been structured.
Yes, it has. It's a great opportunity. Thank you, Claire.
I guess I'll go let you end on some thoughts, Pepper. I would say curiosity. We have a team of our home visiting specialists who are coming from the home visiting world, and so they're curious as to why child welfare does things as they do, and it helps me think through why our system's in place this way. And then as a team, we get to also ask why certain ways are with home visiting. And I know that there's a few questions about working class families. It's true. We talk through all the different issues and how do we just help this specific family. So I think curiosity is always part of the process.
Yes, it is. It should be, for sure. But first, if we stop being curious, then, you know, what are we even doing, right? Yeah. All right. So we've got hope, we've got opportunity, we've got curiosity. All right, Pfeffer, pressure's on.
So I'm going to echo the hope. And when I think about transforming the child welfare system, what gives me hope are these stories, because in the partnerships that Thay's team has with case managers, you can see in one person around one family, case managers shift from, you know, I have to solve this problem and I need to hold people accountable, which, by the way, comes from fear, right? They're dealing with difficult, fearful situations. And you watch them get excited about a service that can provide something like this, and you watch these relationships build, and you realize that working together allows people to free up some of that energy that's around compliance and all those other frightening things, and get you back to why you're here. Both the case manager and the home visitor, in every case that they, you know, talked about today, get to help change the course of a family's life potentially. And so that in and of itself is all people need to go on with how hard it is to create system change. It really keeps you going. And that is in and of itself hopeful.
It is. It is. So lots of wisdom from our panel today. What an exciting conversation. Thank you all, each of you and all of you collectively. We really appreciate it. We do have a survey that we want you to take, participants, if you will, just hang on after we close, but we do need to get feedback. We want to make sure that we know how we're doing while we're trying to do what we feel is important and purposeful work. So thank you again. Thank you to the staff at Build who are behind the scenes. You can't see them, but they're making this whole thing work. Thank you to Build for supporting this work. I want everybody to know that this is the last of the webinar series. It is not the last of Build's work in this area. It is instead the beginning. And so stay tuned. We will be looking at this more moving forward. Again, thanks everybody. Thanks for all of you who came. I hope that you got a lot out of it, and we appreciate you. So keep at it. Thanks. Bye.
Bye.